The given topic for me is understanding of Amlapitta by the help of upper GI endoscopy. See, Amlapitta is treatable by medicine as well as surgical interventions. The instrument which give us a clear-cut line of demarcation to decide whether this is a surgical case or medicine case, that is the upper GI endoscopy, that is the Nadiyantra, which help us to do the Shrotogata Shalyodharanartha, Roga Darshanartha, Achosanartha and Kriya Saukaryartha. Coming to the Avasthapaka, Madhura Avasthapaka takes place in Amashya, Amla Avasthapaka takes place in Pachamanashya, and Katu Avasthapaka takes place in Pakvashya. As we know, if Amla Rasa develops in Amashya, the patient will end up within the Amlapitta. See, that generation of Amla Rasa in Amashya, that could be because of the disproportion between the required amount of Pitta and the food, or a altered chemical constitution, or else a altered anatomy of the Amashya. To know this, we would definitely require a scope or Nadiyantra. See, that's what we call as a Vidagdhata. When the Pitta goes into Vidagdha, becomes Vidagdha, it changes its rasa. The basic rasa of the Pitta is the Katu rasa, and once it moves into the Vidagdhata, then it changes its rasa into Amla. That causes Rutkanta Daha and Amla Udgara. So I take the cardinal features of Amla Pitta. The one which causes Rutkanta Daha and Amla Udgara, that commonly we call it as the Amla Pitta. But to differentiate, we require a tool. That's what I would like to highlight today. See, here you can see that one is the normal upper GI endoscopy finding in the throat itself only, and this one here we can see postlingual tonsillar hypertrophy. See, we are not yet entered into the esophagus. In the throat itself only we come to know whether this is a case of GERD or Amlapitta or what it is. So it's not always mandatory to get into the esophagus. So sometimes even we get the findings in the throat itself only. So is another case, say laryngeal esophageal reflux disorder. So most of the patients who comes with a cough and all, so they are not responding to the common treatment of CASA. So that is the result of the Amlapitta. Here you can see the edematous mucosa in the pharynx. See, this is such a tool. So not yet entered into the esophagus, but we are diagnosing the many cases. This is another case of the candidial esophagitis, that is the Coetzee grade 1, Coetzee grade 2 I have posted here. So candidiasis, here the mucosal lesions are more than 2 mm comes under the Coetzee 2. So here also the patient comes with the complaints of Hrutkanta Daha only. So this is candidial esophagitis, and that is both are infective esophagitis, that is candidial esophagitis, and this is a viral esophagitis. This is cytomegaloviral esophagitis. This is recently I did the endoscopy, and the biopsy has proven that it's a cytomegalo esophagitis. So this patient has come with a history of fever 2 days back, and now he is afebrile, but sudden onset of severe Hrutkanta Daha. So it has proven with the histopathology. So even in case of C. esophagus, we expect the patient to come with the obstructive features, but so the many times the patients comes with the Hrutkanta Daha. So this is a case of ulceroproliferative growth in the lower end of the esophagus, especially whenever it appears in the lower end of the esophagus. So we usually come with patient comes with the GERD symptoms rather than the obstructive features. So this is the most commonest feature, means the condition where we can see the GERD features. Here you can see this is a gastric mucosa, columnar epithelium is there. This is a diaphragmatic crust. I not yet entered the diaphragmatic crust, I have not yet crossed, but I am seeing the mucosa of the stomach here in the thorax. So it's a hiatus hernia. See here in the J manure, we can see a bell shape of condition, that is a very lax grade 4 Hill's grade 4 lax lax LES, lower esophageal sphincter. So it's a bell kind of feature here you can see. This is a clear cut hiatal hernia which causes a repeated regurgitation and gives the presentations like as that of the Hrutkanta Daha and Amlodghara. See, first three classification, let's Hill's grade 1, 2, 3, they are just LES. Only the fourth LES is said to be an hiatus hernia, and we know the sliding hernia is the most common rather than the paraesophageal. So GERD, here you can see a superficial linear erosions in the lower end of the esophagus. So that is because of the pepsin exposure and acid exposure to the squamous epithelium of the esophagus, which causes ulceration. And here you can see, we can see the mucosa of the stomach here, and that itself says that is a lax LES and causes a GERD. And here the concentric rings in the mid esophagus, that is the maybe in glutamine intolerance, colic diseases, so or eosinophilic esophagitis. So just a diet modification is sufficient. The another most commonest cause for the ulceration is the esophagitis. Once they see, what my main intention is, in each and every conditions we get Hrutkanta Daha only as Amlapitta features, but the differentiation we need to make the differentiation, and for that we require this tool. So this case of gastroparesis, see this patient has Hrutkanta Daha only, but diabetic patient, long standing diabetic neuropathy causes and disproportion takes place in the pyloric constriction and relaxation, and after 12 hours of fasting, we can see the food in his corpus of the stomach. See, this is another case of distorted pylorus. See, anatomical variation. So here we can see is antrum. The food is there in the body of the stomach. Here you can see this is a completely distorted, and on magnification you can see the lumen, but it is very narrow lumen. I couldn't able to intubate into the duodenum. So this is the distorted pylorus. So that also causes obstruction, and obstruction leads into the regurgitation, and the patient presents with as that of the GERD. Okay. So this is a case, actually this is not an inflammation, this is a portal hypertension gastropathy. This is a non-inflammatory condition. Because of the back pressure which develops because of the portal vein hypertension, we get a mosaic sign, or the skin as that of the skin of the snake sign. This is in this condition what happens, lower esophageal sphincter become laxed, and that once again causes the GERD symptoms. So we can categorize I have taken only few presentations here. So because of lack of time, we can classify as that of the Kashyapa's categorization, like Krishna Chavamanam. We can take the chronic bleeding disorders, not the acute. Pitavarnam like LES and hiatus hernia and other, and Shweta Chavarnam, like as I have shown the candidial esophagitis, like a curd like vomiting comes. That is in the grade code C, grade 3 and 4, we get such kind of presentation. See, coming to the conclusion, see what looks like ash today may erupt as a flame tomorrow. So it's need a proper evaluation, and with this I would like to conclude my presentation, and I am very thankful to Hemant sir and NII team for giving me an opportunity to be here and considering me. Thank you one and all. Thank you. Thank you, sir.
Congratulations, Dr. Praveen, for your wonderful presentation. This is our